So now it's my pleasure to invite Dr. Spire, Bruno Spire de Marseille, de faire une présentation sur l'adhérence chez les personnes vivant avec le VIH. As this morning he presented in French, and as you know now that Canada is a bilingual country, he will accept, or he has accepted, to present in English to make a good equilibrium. So thank you, Bruno. And I have to say that Bruno has a particularity to be a MD, a physician, a PhD in virology and social science, and be an activist and work for, or preside, or the chief of the association Aide France. Merci, Bruno.
Merci, Jean-Pierre. I would like first to apologize for my French accent. You will have to do with it. So I'm going to talk about adherence, and just to give you an explanation of how we were involved in this adherence issue as social scientists. We were approached by the clinicians when the triple therapy arrived in 1997, because the clinicians were able to see that these treatments were very efficient. But they realized quite quickly that some patients didn't want to take these drugs properly, or could not take these drugs properly. And it was very intriguing for the clinician at that time. And they were completely confused to have something very powerful, the antiretroviral therapy, that was not actually taken by people who really need them. So when clinicians are confused, they usually ask social scientists to help them. And it's what we did. And we were involved in these studies, in multidisciplinary studies, to understand the adherence issues. And I'm going to give you some messages of the main messages of what we found. And the data we collected were through two multidisciplinary cohorts. The first cohort was the APROCO copilot cohort. It's the cohort of the first generation of patients who were treated with multiple therapy. First, they got PI-based regimen because it was the only regimen available at that time, and then they could switch anytime. And the APROCO copilot was the data collection was finished only last year, so we have a really long time period of observation. And the originality of this cohort is that it's not only data collection of medical data and biological data, it's also data collection of socio-behavioral data. Patients had to fill in a self-administered questionnaire twice a year. And so we have plenty of data concerning adherence, quality of life, mental health, conditions of living, which is quite interesting. The second cohort is the MANIF cohort. It's the same spirit of APROCO cohort, but the specificity is that it enrolled patients who are HIV infected through intravenous drug use. So it's mainly a cohort which was active in the south of France, because the south of France, the problem of injecting drug use was quite prevalent. So what are the key messages we found? So the first message is that adherence to antiretroviral therapy is a dynamic process. And just before I explain this message, just a few words to tell you how we measure the adherence. We used some questions in the self-administered questionnaires. The questions were based on the last 4 days of medication, because if it's too long time period before to remember it, there are too many recall bias. And we also introduced additional questions to increase the possibility to detect non-adherence behaviors, because self-questionnaires are usually not very sensitive to detect non-adherence. And with these additional questions, the questionnaire was better. Of course, it had to be anonymous, and the doctors could not have access to the questionnaires that were filled in by patients, and patients were told about that to to avoid social desirability bias. And from this questionnaire, we were able to classify patients in 3 categories: those who were highly adherent, so it corresponds to 100% of doses prescribed which were actually taken; moderately adherent, it's between 80 and 99%, and non-adherent, which is below 80%. So what are the results of this dynamic of adherence? You can see here on the left panel of this slide, you have the proportion of highly adherent patients during the 3 first years of follow-up. And it seems like it's quite stable between 54 and 60%. But actually, these are not the same patients at each time point. And if you look here, you can see that the majority of patients are highly adherent sometimes only. Only 26% are always highly adherent, and 10% are never highly adherent. So the question is, when is it necessary to be highly adherent? And we try on this slide to assess the role of early adherence on prolonged virological success. So what is prolonged virological success? It was a 3-year study. So we consider prolonged virological success for the patients who were actually suppressed during the whole 3rd year. And here you see that the patients who were initially highly adherent at M4 had a much better likelihood to be in prolonged virological success. Unfortunately, it was something very different when we are looking for the adherence in the maintenance period. Here we classify the patients as patients that were always highly adherent. Here you have the patients who were either highly adherent or moderately adherent. And here you have the patients who, during the maintenance period, could at least have 1 episode of non-adherence. And we did not see any difference of prolonged virological success between those patients who are the ideal patients and these patients who sometimes are not highly adherent but never fall in the non-adherence category. So in other words, the impact of adherence is much more important in the induction phase than in the maintenance phase. And I don't know why it's in French here and English. Because the English is here, okay. I was confused. And so the interventions that have to be done, if you have not enough staff, for instance, staff has to be really prioritized for the early interventions during the induction phase. The second key message we were able to draw from these studies is that adherence is poorly predictable before treatment. And before we started these cohort studies, there was a huge controversy in the literature between those who were thinking that the adherence could be predicted before treatment and those who were thinking that it was not possible to predict it. So what were the arguments? There were many people, many doctors, who wanted to predict adherence on the sole basis on some socio-demographic characteristics, and they wanted to design research to try to find these characteristics. And the idea was to target the best population that could be eligible for treatment and to exclude some patients of treatment, not to spoil any treatment. That was a kind of extreme attitude. Some were a bit less extreme and wanted to use this predictive approach to try to educate the patient before they start the treatment, and if they met the eligibility criteria, to treat them afterwards. But there was the other theory of the empathic approach that was based on works that were already done by social scientists on other disease, and that was thinking that experience is a major determinant for influencing adherence. And also, they were criticizing the predictive approach that was mainly based on cross-sectional studies and not on longitudinal studies, and it did not take into account the evolution over time. So who was right? We were able in the APROCO cohort to try to figure out if it was the predictivists who were right or if it was the empathic who were right. And overall, the predictivists were wrong, but not completely. There were some limited socio-demographic predictors that were able to be identified, like young age, poor social conditions, and lack of social support. But these factors have very weak explanatory power in the predictive models. So it means if you predict only on this basis, you cannot be really sure if the patient will be adherent or non-adherent. Most of the variables that were able to explain the adherence behavior were drawn from the experience of the patient on treatment. And these variables are related to perceived side effects and perceived efficacy. So the patients who really feel much better during treatment, who have the impression that they are relieved, they will be more adherent. And those patients who think they are poisonous because of the treatment and they experience many side effects, these patients are much more likely to be non-adherent. So it's this kind of variable that's much more predictable of adherence. So they need to be on treatment. And before treatment, it's impossible to predict. Another important message is that we could not identify any transmission group that could be associated with non-adherence. In our cohort, injecting drug users group were not different in terms of adherence than heterosexual transmission group or homosexual transmission group. There was no difference. And even more, in the MANIF cohort that was made only of injecting drug use transmission category, we had several subgroups. We had those who were completely abstinent, no more dependent. We had those who were still in the streets finding some heroin. And we have those who were on buprenorphine or methadone and who were in these harm reduction programs. And those who were the most adherent were those with methadone or buprenorphine. They were even more adherent than those who had no more dependence at all. So there is a very important role of this perception of side effects. This is the list of symptoms that were put in the questionnaire, and patients have to fill in if they get this, if they report this symptom or not. And the more the symptoms they reported, and the more likely they could be classified as non-adherent. So it's an important thing because these symptoms is not really objective toxicity, but it is for the patients. It is what they experience with the treatment. And that's the best variable which is related with non-adherence. If you use the toxicity which is measured by the doctors in the medical files, you can't find any statistical relationship with adherence or non-adherence. So it's not the medical toxicity which is important. It's the subjective toxicity which is perceived by the patient because it's the patient who feels well or bad with the drugs he has. So what about the treatment complexity and adherence in our cohorts? We never could see any impact of the number of pills on adherence behavior. And in the long-term analysis of this cohort, we were able to show that the patients who had 3 times a day regimen were less likely to be adherent than those who had twice a day or once a day regimen. But we could not find in a study any argument in favor of the once a day regimen. It was even worse. Those with once a day were usually less adherent than twice a day, but probably it's a kind of indication bias because those who had problem of adherence were more likely to be prescribed on once a day regimen by the clinician. So the last key message I'd like to share with you is about the counseling and support that improve adherence. So this, we did not use the cohort that I mentioned to show this message, but we try to evaluate the impact of adherence counseling on virological outcomes in a kind of a standard clinic. It was in the Nice hospital, and we designed a randomized controlled trial to compare two arms, standard of care versus standards of care, plus educational and counseling. The counseling was performed by nurses that were specifically trained, and what is very important is that the counseling was centered on patient and not centered on the regimen. It means that the nurses were talking during 45 minutes with the patient about personal life, affective life, sexual life, professional life, and not only on treatment and viral load. What are the results we could observe? We could see that there was, in the intervention arm, there was a significant decrease of viral load, which was statistically significant, and there was no decrease of viral load in the control arm between M0 and M6. And the proportion of patients who were undetectable was higher in the intervention group when compared with the control group, although we did not reach the statistical significance. But it was the standard clinic, a standard group of patients, and at enrollment, there was already something like half of them who were undetectable. So if we did the analysis of the subgroup of patients who were detectable at enrollment, if you compare after 6 months, you can see a statistical effect of the intervention with the counseling. And of course, we could observe better adherence among the patients who had the counseling when compared with the patients who had only the standard of care. So when we compare several adherence interventions, there were other interventions in France that were performed. Our intervention was the only one who was able to show an effect on the viral load. Most of the other interventions only show an effect on the behavior. And probably we explain this result, this really positive result, by the way the counseling was done, because our counseling was centered on the patient. And when you read the theory of psychosocial change, we know that to change your behavior, you require to have more information, but information is not enough. You also need to increase motivations and to build capacity to increase skills. And that was not possible when you have a counseling which is only centered on the regimen and on the schedules. You don't increase motivations and skills, and which was more easier to reach in our counseling that was centered on patient. We also collaborate with Médecins Sans Frontières, who experiment treatment access in a Cambodian program in Phnom Penh. And patients had only, these quite old regimens, mainly based on Triomune, D40, 3TC, nevirapine. And in this cohort, all the patients had this counseling, which was exactly the same counseling that we experiment in Nice. And what is interesting, that even in this completely different context, after 2 years of treatment, we have about 95% of patients who are highly adherent patients, and we have 80% of patients who have undetectable viral load below 40 copies per ml. So these very excellent results are probably due to the high quality of counseling, which is centered on the patient needs. Okay, I would just like to finish to thank all the collaborators of our team, which are mainly the collaborators in the clinical centers. There are many work to collect all this data, and I really like to thank them because it's really a collective project. Thank you for your attention.
So, question?
Je voulais juste dire à Bruno que c'est une très belle... C'est un commentaire plutôt qu'une question. C'est une très belle... Ceci illustre très bien ce que nous vivons sur le terrain. Parce que si nous avons une approche centrée sur le patient plutôt qu'une approche sur le régime, le résultat que nous avons est meilleur que s'il est basé sur le... Alors, le seul commentaire que je voulais ajouter, c'est, faisant suite à votre présentation ce matin, je voulais dire que la prévention, elle est mieux si elle est personnalisée. Pas seulement personnalisée aux individus, même si elle est personnalisée par rapport au groupe ciblé et aussi à la population ou groupe ciblé. Ça, c'est vraiment le commentaire que j'ai. Je suis un petit peu émotif parce que ceci cadre parfaitement avec ce que nous avons observé sur le terrain. Merci.
Thank you.
Thank you for your presentation. So I'm curious to know what led that you decide to ask adherence for the last 4 days, but not for 2 days or not for 1 week.
Well, it's we used the last 4 days because there were already some publications in the literature that use last 4 days, and usually when you try to set up a questionnaire, first you do the literature and you look what the others have done, and you try to reproduce to be comparable. But there were, after our works, there were other works we were doing with 1 week or with 3 days, and most of the results are usually about the same. It's just an indication of the recent period. But it's a way of standardizing the questionnaire and ask, yesterday, what did you take in the morning? What did you take in the evening, the day before, the day before? And when you have 4 days, it's a kind of usual way to imagine that after 4 days, it's too complicated to remember. You know, it's like food. If you ask you what did you have for food yesterday, you can maybe remember the day before, okay, the day before, okay. But then it starts to be quite complicated.
Thank you. We have one question by card.
Why were nurses asked to do the counseling and not the social workers? That's a good question, but I think it's not, it was nurses because there were many nurses in the hospitals at that time, because the hospitals had still a big staff, because it was rather few years only after the dark period. And so there was this staff available, and they could train them on counseling for those who were motivated. But counseling, you know, could be done by anybody who wants to do counseling and be trained for it. It could be social workers, it could be pharmacists, it could be people living with HIV. And actually, the first counseling that was done before this experiment was done by people living with HIV in associations. And the psychologists who designed who standardized the counseling, what did she came in the association, she observed what was going on, and she put it in a good frame to be able to be reproduced by anyone outside the associations. So I don't think it's really a problem of who is doing it. The real problem is to do it properly and to be trained for it.
Thank you.